So thank you for the previous session, and I'm thankful to Dr. Partha for having several trauma sessions, and I'm there from morning. So first speaker is Dr. Kerobilairi, who's going to speak us on classification of ocular trauma, what's new.
MacBook, yeah.
So in the team, and
This is not a C type. This is the other one. You want that one? I'll give it to you.
Akshay, where is he? Where is Akshay gone? Oh, next.
He's here
next.
only.
Okay. And followed by Akshay is Dr. Kavita Rao, then myself, and finally Aishwarya. You are in this session? Yes, you
No
are.
idea.
Yeah. So, you are giving the keynote address. We have Dr. Naresh Motwani from UK. Will be giving the keynote address.
He'll give it now.
You will give it first. Okay. No. You already uploaded. Yeah, sure. No. Unfortunately, they put in the last part. Yeah. Okay. So Dr. Naresh Motwani is originally from Delhi and now in UK. He is going to give the keynote address on ocular trauma, interactive, comprehensively managing ocular trauma in the era of ophthalmic subspecialization. Yes, welcome, Naresh. How are you? No, they're not displacing. You are in the program. Your microphone has to be on.
लाल बत्ती तो नहीं आई आ गई okay thank you Prof Natarajan and thank you to the organizers and most importantly thank you to the audience who have chosen to come to this session instead of so many other sessions ongoing. I was going to say it's my pleasure, but it has been more of a fun for me to come here. A missed flight, missed baggage, finally no suit to wear, but there we go. I'll talk of fun later. So I was looking at English language, keynote speaker. So what keynote speaker does is introduces and sets the theme. That's why I wanted to come first, sir. Engage, entertain, and maybe a bit educational also. So in the fun bit, my micro SD card, so that is educational also for you. The micro SD card was kept next to the phone. And when I put the micro SD card in the computer, it says no files. So here I am with all the complex things, and I was the slides missing. So my talk was supposed to be ocular trauma management, interactive in era of super specialization. So interactive means if I do something, I want my audience to participate also. Will you? Okay. So the first question, how many colleagues in this hall regularly manage the cases of ocular trauma? Fantastic. Do you think is super specialization of ophthalmology necessary for managing ocular trauma in all cases? Show of hands, yes. No? Just 1, 2, 3, that's all. So minority say you don't, minority say that you don't need the super specialization. Okay, last question, not last, but last for now. How many of us feel that most cases of ocular trauma need to be managed in a center providing super specialist ophthalmic care? Wow, so let's say majority again. Prof, let's start with a bit of monologue. So what is the ocular trauma? The first thing that you can imagine in your head as an ocular trauma case, if I say ocular trauma, anybody wants to tell me? A case. No. अरे यार वो बैडमिंटन खेल रहा था, something like, yeah, okay, come. Oh by God, I have that one, and that slap caused giant retinal tear. All right, okay, anybody else? And what happened to the eye? Okay, anybody else? बड़े सारे हाथ खड़े हुए थे. Regularly ocular ट्रॉमा मैनेज करने वाले? प्रॉफ ने बताया उससे पहले आंख, there was a nail in the eye, etc., etc. So I would like to start, I'm really going basic now, because on paper and pencil, you can't do anything more than basic. And I think the basics are very necessary for us to build on the super specialization. So when I say ocular trauma, I see the whole range: closed globe, open globe. When I say ocular trauma, I mean masterly inactivity in one, and on the other end, multi-speciality staged surgical intervention. So, ocular trauma, subconjunctival hemorrhage. Who will do a surgical intervention? Oh my gosh, I've got a unanimous vote. Ocular trauma, slap by the child, inadvertent slap by the child, corneal abrasion. Who will do a surgical intervention? Okay, not as a primary, but as a secondary, I have done a few, because then it becomes recurrent corneal abrasion, then it becomes la 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 la, and then you used to do the needles and now the lasers. So, in all, what I'm trying to say is, when I say comprehensive ocular trauma management, I'm not only looking at the surgical interventions with all the things that Prof was showing just now, and he's fantastic at it. I can't do any of those, but there we go. And one thing I want you to remember always, as I said, a bit educational also. So let's remind you that the eyes are not exclusive. They are housed in a skull, which is connected to the neck. Neck is holding the skull. Head trauma, head injuries are to be ruled out. And a good assessment, only a good assessment, a thorough assessment, will help you to manage a comprehensive patient of ocular trauma. Okay, once again, a show of hands. Do all open globe injuries need surgical intervention? All? No, not all. Okay, so people who've not raised hand, can you give me one example, please? जोर से बोलो, सारे बोलो. Anybody? Do you remember Spitfire pilots? Spitfire pilots were the way forward when the intraocular lenses started having acrylic. Otherwise, it was glass, which was started with sunk intraocular lens, Spitfire pilots, intraocular ocular trauma, no surgical intervention. Okay, and there are many more other examples. So similarly, closed globe injuries, they might need surgical intervention. But most of the closed globe injuries, don't need at least a primary surgical intervention. But again, assessment, thorough assessment. You think of the patient who I was talking about, the giant retinal tear, did not give history of trauma, social embarrassment, whatever. It was only later on in confidence that the patient said, oh, it was here, the trauma, it wasn't at the eye. Sure. Okay, so let me just come to the fun part of it. I said in the beginning that it was my pleasure, but now it is more like a roller coaster. So I missed my flight. My luggage got delayed. It's all called a snowball effect. And then when the luggage came, I had a bit of other problems. Because I was late by a day, 24-hour flight, the hotel cancelled my room, etc., etc. The same will happen with the ocular management, ocular trauma management. You miss the first bit, you keep going into the spiral. So be prepared. Again, I'm stealing this from, I think it was you who said, game of soccer. Be prepared for surprises. You plan very well, you go in and you suddenly find something else, and know thy limitations. If you know you can't or you might not be able to, get another person who might be able to, but still be prepared for surprises. Okay? Nobody can manage all the cases of ocular trauma, especially the complex and severe ones. I remember a child being bitten by a dog. Lots of, all I could see was a mangled mess here of tissues dangling. I could not see the eye. And the child was about 4 years old, brought in by grandparents. There was lots of chaos, lots of. So the first thing you have to do is take charge and assess the situation, assessment, so that you know whether the eye is involved or not. Okay, so I love to collect coins. It's called numismatist. Did you know that? How many of you knew that? Educational. Wow. At least for some it was educational. So they say husband and wife are two sides of the coin, always live with each other, but never face each other. Well, mostly. So let's look at the other side of this situation, ocular trauma, subspecialization era. So super specialization is very much needed. The expertise and experience of these guys who are super specialty trained is needed. For example, for that child, I debrided the whole thing, but it had to be an oculoplasty trained surgeon who could put the electrolymal cannula, etc., to repair, to make a definitive, and thankfully that child's eye was saved or was not affected. So if super specialization is started in the initial stages of training, that is where the problem is. They don't get to know the basics. And corneal suturing. One of my trainees called me over because he could not suture a cornea. It was a simple, okay, it was a 7 millimeter corneal perforation, no other extension. It had to be sutured. He could not do it because he'd only done the phacos and the lasers and the. So as trainers, it is for us to remember that all these trainees, we have to go back to basics. Human first, doctor next, and ophthalmologist next, super specialist next. If we forget this simple rule of going step by step, we will get unstuck one fine day. I had lots of examples on the slides. Glaucoma, there was a case where cricket ball went through the helmet grill, ciliary body detachment, tried to manage medically, hypotony continued, and it had to be, the ciliary body needed to be sutured, needed a glaucoma expert who was expert in doing that. Or the slap in the face, needed a vitreoretinal surgeon. There was a badminton player who came to us, orbital blowout, sunken globe, trapped inferior rectus. I couldn't have done it. So there we are, guys. I've got lots of other examples, and there were lots of lovely slides, but I hope it was a bit educational, and that is going to be the theme of the coming talks. Thank you.
Thank you, Dr. Naresh. I always enjoy, and I'm glad you managed your talk by educating us. Thank you very much. We learned every time we learn something from somebody. Thank you. So next, I invite Dr. Karabirelli to to speak on classification of ocular trauma. What's new? And actually, in Asia Pacific, we have termed it as ophthalmic trauma instead of ocular, because oculus means the bulb eye, the eyeball, and so we want that next, so that we have included Akshay Nair, who's the next speaker.
Good morning, everybody. Thank you, Dr. Natarajan, for including me in your instruction course. I will be talking about ophthalmic trauma, an update on classification and recent terminology. Devising a classification system in medical science is often a challenging task due to the complexity and variability of the human anatomy and physiology. To classify all cases of trauma, to add 3 categories is necessary: non-mechanical injury, adnexal injury, and destructive globe injuries, which is not there in the current classification. So that is the reason why a proposed new classification was designed, which is broader based and comprehensive, to allow a wider range of classification of ocular injuries not covered by the current classification, as a fifth of mechanical injuries involves the ocular adnexa. So it's very important that that is also fitted into this classification. Now, the BETS classification satisfies all criteria for standard terminology by providing a clear definition for all injury types and placing each injury type within the framework of all of our comprehensive system. So, what is the best classification? BETS classification, it is a closed globe and open globe injury, where the closed globe comprises of contusion and lamellar laceration, and the open globe comprises of the rupture and laceration, where it is a penetrating, perforating, or an intraocular foreign body, which is the kind of injury that is there. So in 1996, Kuhn et al. Defined various terms used in ocular trauma and made a classification of ocular trauma for mechanical eye injuries. In this conventional classification, mechanical eye injuries were classified into open and closed globe, as I showed you. Now, what were the subgroups? The eyeball was the sclera and the cornea. The closed globe was no full thickness injury. Open globe was full thickness injury. Contusion was no full thickness injury, generally a blunt injury. And a lamellar laceration was a partial thickness injury of the eyeball, generally a sharp injury. And in the open globe subgroups, a rupture is a full thickness injury of the eyeball by a blunt object. A laceration is a full thickness injury of the eyeball caused by a sharp object. Laceration subgroups are those of a penetrating injury, where there is a single laceration of the eyeball, no exit wound. Intraocular foreign bodies, which with retained objects causing an entrance wound, and perforating injuries, where two full thickness lacerations are there with an entrance and an exit injury. So this was the classification which was given. And in 2009, a new classification of ocular trauma was proposed, which was a general classification which comprised of local, associated, and cause of injury. Now, local was mechanical and non-mechanical. In the mechanical injuries, there were globe injuries, destructive globe injuries, and adnexal injuries, which involved the orbit, palpebral fissures, and the lacrimal and conjunctival areas. And in the non-mechanical injuries, there were the chemical injuries, thermal injuries, radiation, and electrical injuries. In the general classification, associated injuries were associated in and around the eye, that is a head injury, a facial injury, or multiple injuries of any kind. And the cause of injury again was industrial, sports related, road traffic accidents, assaults, agricultural, or something concerned with daily activities. So when we see this classification, there was a further classification of the mechanical global injury into a structural and a pathological. The structural was concerned with the coats of the eyeball and the areas of the eyeball, that is the anterior segment and the posterior segment, where anything could be affected. And the pathological was again the three groups, that is the closed globe injuries, which comprised of a contusion, which was lamellar, or a laceration, an extraocular foreign body, an intramural foreign body, or a dislocation. An open globe was again a rupture, penetration, perforation, intraocular foreign body, and destructive globe injuries, which were evisceration. There was an enucleation in some, full thickness laceration with affecting 1/3 globe circumference. Now, there were three zones of the eyeball which were listed. The zone 1 was involving up to the limbus, the corneal part. The zone 2 was a zone 5 millimeters from the limbus onto the sclera, and the remaining came in the zone 3. Now, the zone 3 was affecting, like anything of the posterior segment fell in that category. So this is like the kinds of involvement that you get of different structures in the eye. And then there came a study by Dr. Shukla et al. We are sorry he's no more with us, but he had designed a classification which allowed for classification of 535 causes of ocular injury, whereas the current classification is only of about 364 causes. So injuries which involved the adnexa, non-mechanical injuries, destructive eye injuries, could not be classified by the conventional classification. Therefore, 33% was missing, and that was what he further classified. The classifications were approximately the same that I have already listed before. And he came to the point, again, the types were the same, that open globe, closed globe, and destructive. And what was more prevalent in his series was in the anterior segment, he found that more commonly the cornea or the lens was involved. In the posterior segment, the retina was involved or the choroid was involved. In facial injuries were more common in the associated injuries, followed by multiple injuries. And what was missing in the old classification is the most common closed globe injury was that of a contusion, which followed by a lamellar laceration, and the most common open globe injury was that of a rupture. So this was, of course, whatever the thing was, you manage accordingly. The management was by accurate history, examination, CT scan, MRI scans, and this is again a list. Now, there is something called as an OTS score, which he had designed, where there was no classifications or investigations or treatment guidelines that are internationally standardized and practiced. And there are numerous controversies and variability of the practice standards. And we herewith review the existing literature related to the relevance and practice of the ocular trauma score to highlight validated and effective predictive models. Now, its application was to predict visual outcomes and also to help audit outcomes when the predictive outcomes are not achieved. So this was how the OTS score was done, where the vision was the most important part, which gave you points, raw points like 60, 70, PL had 70, 1 by 200, 19 by 200 was 80, 20 by 200 to 20 by 50 was 90, and greater than 20 by 40 was 100. And there were negative marks for globe rupture, which was minus 23, endophthalmitis, minus 17, and so on and so forth. So you could have a rough calculation of what to expect if a surgery was done in this patient and how much to prognosticate to a patient. There is another called as an abbreviated injury scale, which is anatomically based, consensus driven global severity scoring system that classifies each injury in every body region according to its relative severity. And it's a 6-point ordinal scale from minor to maximal, where the face and eyes are important components. So, despite all this, there were certain things which were totally missed out in children where they turned amblyopic after probably traumatic cataract surgeries and strabismus, refractive errors, and ocular opacities. These were not grouped in any of the classifications. So they decided to have another mathematical model called pediatric OTS or the POTS. Now, along with the POTS, the Drishti Netralaya of Dr. Mehul Shah, and they have proposed another classification called TOTS, which is the Toddler Infant OTS, which was recently designed for children less than 6 years with open globe injuries resulting from trauma. The visual acuity and its benefits for prognosis prediction for traumatic cataracts with associated surrounding injuries like hyphemas, iris injuries, retinal detachments, or vitreous hemorrhage greater than 48 hours delay in surgery, and endophthalmitis. The trauma score calculation in the TOTS was visual acuity was equal to 2x in this age plus zone minus corresponding pathologies. And this gives you the kind of grading to prognosticate in this classification. Thank you so much for your kind attention.
Thank you, Kerubi. Dr. Naresh, you want to say something? Anybody else wants to comment? In the meantime, can I invite Akshay Nair? He's missed his last talk. Here he is going to speak on evaluation and management of adnexal trauma.
Yeah, actually, I'm going to continue. I'm going to speak on my previous talk from the previous session, which is eyelid trauma. The top 3 challenges. Right. So I'm talking about top 3 challenges or unique cases that we may see that pertain to eyelid trauma and how we can manage them. So I have no relevant financial disclosure. So of course, as Dr. Naresh said earlier, the first thing is to assess the severity, uh, to assess the patient as a whole. And once you do that, then you can assess the eyelid. And then once you've cleared the eyelid, the debris, then you can know if the globe is involved. If the patient is critical, unconscious, non-responsive, do not bother about the status of the eye. We need the patient to be alive before we can operate on the eye. So on the eyelid and the lips, the first challenging case that I'm going to talk about is a dog bite, touching on where we already spoke about earlier. Remember how a dog lunges forward, and the most common, our initial reaction is always moving away or moving downward, which is why the eyelids and the lips are the most common parts of the face that are bitten by dogs. It is an absolute emergency, and the first aid is to clean the wound thoroughly with water and soap if available. Now, how many of y'all would, a show of hands, would suture a dog bite to the eyelid immediately? None. And I'm happy to say that then this talk will change your mind. An eyelid wound is the only wound in the body where you are supposed to suture the wound, even if it is caused by a dog bite. The first thing is adequate wound cleaning, a tetanus toxin, and your rabies prophylaxis has to begin on its own. The schedule of your rabies prophylaxis is independent of what you do anywhere else in the eye or the body. And remember, if the upper eyelid is avulsed or the upper eyelid is detached, especially if you have an avulsion eyelid where the flap is 4 times, the length of the flap is 4 or 5 times the width, it's a matter of a couple of days. Yeah, it's only a matter of a couple of days before that avascular flap becomes necrosis. And you can't wait and say that, oh, this is a dog bite, we can't suture. It requires immediate surgical reconstruction in layers. You need to restore the anatomy and the function. And these are the cases where you have to give immunoglobulin to the patient. Now, remember, the vaccine schedule goes on as is, but the immunoglobulin, the IVIG, has to be given at a distant site, away from the same site of your vaccine injection, and in a different syringe. We've actually seen them being mixed, which basically negates the action of one and the other. You have got immunoglobulin and the attenuated virus in the same vial, which is going to negate each other. So different syringes, different sites. A dog bite has to be reconstructed immediately. Can I leave this patient dangling with that flap for more than 2 days? You can't. The lid will be complete, the entire flap will become necrotic. It's already become necrotic. You can look at the tip of that, the dangling part there. It's becoming black. And also, if I don't repair it, then the eyelid, there'll be lag ophthalmos, corneal exposure, and then you have keratopathy related issues. So dog bite is the first challenging case that we need to be aware of and how to treat it. The second is canalicular tear. Remember, the broad rule in canalicular tears is earlier you repair, the better the outcomes. Because the earlier you repair, the easier it is to visualize the cut ends of the canaliculi, the easier it is to intubate them, and the more you intubate these cut canaliculi, the more chances that functionally they'll perform in terms of draining the tears. In children especially, we see this, and in children in India, we know this is very common in children under the age of 2. It's something that we call feeding associated canalicular tear, or FACT, F-A-C-T. 70% of them are under the age of 2, children under the age of 2. What happens is when the child is breastfeeding, the mother wearing a sari and a blouse typically disengages 1 or 2 hooks on the blouse to feed the child. The lower eyelid engages the hook of the blouse engages the lower eyelid, and there's a traction, full pull force, a force that is pulled anteriorly. The canaliculus, being the thinnest and the weakest part of the lower lid, snaps there, and you end up getting a canalicular tear. So I'll just go through a quick video highlighting how a canalicular tear can be done, repaired. Can I scroll? I can't scroll this. Can I scroll this ahead? This is a 3-minute long video. Okay, anyway, so the most important thing is to identify the cut end. First we put in a punctum dilator, dilate the proximal end, and see where it leads to. You'll have the punctum, you'll have the proximal cut end identified. This is basically the most important thing, identification of the cut distal end. And here you can actually visualize that there is a nice pink mucosal ring around the cut end. Put in your cannula with saline and irrigate and see where it goes. If it goes in through the nose, then you know that is the cut end. The other way you can also do is put in a drop of adrenaline. It causes vasoconstriction all around except the pink mucosal lips of that, of the cut canaliculus. So that's another way of identifying. Then putting in a monocanalicular tube or a mini monoca is extremely important. You want to trim it such that there's a beveled edge, a beveled sharp edge, not a sharp edge, rather a slanting edge passes in more easily. You pass it through the proximal punctum and the cut end, and then it's got a self-retaining hammerhead. So that hammerhead can just be gently pulled, so it snugly fits into the punctum and stays there. It's a self-retaining one, so you don't need to suture it. And then of course the other end is guided gently into the cut end of the distal canaliculus. And there you go. If you found the canaliculus and it's not a false passage, it would never pass in so much. Once this is done, you have to take pericanalicular bites of the orbicularis around this. You don't need to take canalicular end to canalicular end bites. Once you do this, this silicone tube acts as a stent around which the mucosa granulates and heals well. The orbicularis is closed in layers with 6O vicryl or 8O vicryl. And then of course the skin can be closed with a suture of your choice. So these things are removed typically at 6 weeks, and then you can irrigate again. So the third challenging case that I'm going to talk about is trauma. So oftentimes we come across a patient who's had trauma. This was a 43-year-old female who had a history of a trauma, a slap on the face. She had blurred vision and ptosis. She'd gone to an ophthalmologist elsewhere who advised an MRI and an MRA, and it turned out to be normal. Now, of course, in a patient with ptosis and anisocoria with a history of recent trauma, MRA is necessary because you want to rule out a dissecting aneurysm of the internal carotid artery. So an MRA was done, it was normal, so it was called a third nerve palsy, and so just come back later, given a course of oral steroids. After a month, the patient was referred to me saying she hasn't improved, we need to plan ptosis surgery. So all I did was call her back after 3 months, and here she's in April with a little more recovery, and then in June with even more recovery. And she didn't come back since, so it's only safe to assume that she'd completely recovered. So traumatic ptosis, time is your best friend. Wait for 6 months, don't even bother about repairing traumatic ptosis, provided the history and the timeline of trauma preceding the ptosis is well established. If there is trivial trauma that doesn't correspond to ptosis, then investigate for myasthenia or thyroid eye disease. Thyroid eye disease, yes, not only lid retraction, can also present as sudden onset trauma. And patient may try to rationalize saying, no, I hit my hand when I woke up and since then it's fallen. Your own hand hitting your eyelid causing traumatic ptosis is unlikely. Rule out other things. Oftentimes undergoing a long surgery like a retina surgery or something with a speculum stretching the eyelids can cause some amount of levator dehiscence. So if the patient has had surgery following which the patient has come to you for ptosis, again wait for 6 to 9 months after surgery for spontaneous resolution, especially cataract or other surgeries that require the speculum to be placed in the palpebral fissure. A lot of patients nowadays, of course, with better treatment options for uveitis, posterior subtenons isn't not that common, but typically we used to earlier see a lot of patients with PST and come back with ptosis. Again, do nothing for 3 months, allow the steroid to be absorbed and then see them. So while we may have these challenging cases, let's not forget the basics. When you have an eyelid tear, identify the layers, secure the edges, first the canthi. The layers have to be, the eyelid layers have to be closed in layers posterior to anterior. Conjunctiva first, levator second, orbicularis, and then skin. If there's any devitalized black or necrotic skin, remove that. If it's the lower lid that's damaged or avulsed or there's a defect, that is not an emergency. You can wait if there's no danger of imminent exposure. Laissez-faire is always an option. So I think this was the whole idea of this talk, to give some overview of challenging cases and back to the basics recall. Thank you.
Thank you, Akshay. And in Aditya Jyoth, we are happy to have Dr. Akshay with us. Yes, Dr. Naresh. In the meantime, can we have Kavita Rao to...
Can you just use the mic?
No.
It's not easy at all, so don't be fooled. Number two, the corresponding history, the history to correspond with the science is very, very important. Point to be noted and fantastic presentation. But Akshay, for dog bite, I wanted to ask you surgical repair. I will do the primary only as, and there's no absolute, there's only one absolute. Otherwise, there's nothing absolute. You could be right today, I could be wrong today, and the vice versa. So in the dog bite, when the patient comes, we do all the primary things exactly as you said, running parallel. Patient needs to be alive before we talk of the eye. And in the surgical repair bit, I would wait for a day, not for a week or so that things settle down. Unless you have a calm, carefully assessed stage, you can't keep taking patient back to the theater. So yes, it should be done within 2 days. It should be done as early as practically possible. But please, as primary procedure, unless you have ocular expertise like Akshay has, don't dare.
Akshay, I have a question for you. There are two questions, in fact. What is the length of the mini manuka that you keep when you sort of put it inside that tone end? And the second question is that the immunoglobulins and the Rabipure which you give, do you put it at the edges of the lids when you finish the surgery?
So I think both are great questions. The first thing is the mini monoca is of 40 mm, 4 centimeters. That's obviously much longer than is needed. So you can always trim it, but even if you don't trim it, what happens is, because it's so flexible, you can keep pushing it till it coils within the lacrimal sac, and then it just stays there. And because it's bio-inert, it's silicone, it doesn't incite inflammation or infection. Once you pull out after about 6 weeks, it comes back as is, uncoiled.
But doesn't it narrow the lumen of the sac?
It does, but it's like rice in a vase. There's always some space around it through
Okay.
which the tears can go down. About the dog bite, yes. Rabipur is again given on a limb or the buttocks, or basically Rabipur is the purified extract vaccine. But immunoglobulins, especially when there is a head, neck, face bite, should be given as close to the site of injury as is given. So yes, you do inject it at the end of the surgery and not at the beginning, so that your mucosal sites, your apposition, and the layers of the eyelid are not edematous and you don't undercorrect them. Sami, yeah, I know he's had a lot of experience with dog bites. Okay. Yeah.
In the sac, that I think will be adequate when you insert. Because in the initial cases, when you are practicing mini monoca, it may not be very visible or comfortable in inserting the entire length of the mini monoca into the sac.
Right.
So if you just trim it to the required length, it will be very easy. So what we need is the complete canalization up to the sac.
The point is that the mini monoca just has to stay across the cut edges. How much is in the sac really doesn't matter. Agreed. Point taken.
And you remove it after 6 weeks.
After 6 weeks, yeah, that's ideal.
Do you take the history also for dog bite? The
Yeah. Yes, in India usually it's a stray dog, but in India usually, I mean, the history and proof of vaccination is so unreliable. You just assume it's an unvaccinated dog.
No, even pet dogs are known to bite because, yes, my own husband was nose was bitten by our own dog, so
Must be your pet.
yeah. I don't like his undertone.
Yeah, I have a question regarding the canalicular repair. Till what stage can you actually do it? For example, if the for example, the injury is 48 hours back, would you still go ahead and try to do the canalicular intubation?
Right. So actually, there's this great paper that was published in OPRS that compared early canalicular tear with delayed, and delayed was greater than 7 days. And they actually found that eventual success rate and complications like tube extrusion granuloma were identical in both groups. But the thing is, like Sir said, if there's someone who's expertly trained in that, then week here and there may not make a difference. But I mean, if you occasionally do it, then it's better to do that earlier so you can visualize the cut ends. But there is no difference in outcomes and success rates early, less than a week and more than a week. I have done cases even 3 months old. It takes a lot of digging, and in those cases, it's useful to use a pigtail probe because then you can go through the upper canaliculums, upper punctum, and then automatically it anatomically leads to the cut end of the other lower canaliculus.
Mostly, I wanted to ask you,
Okay, I'll find out
is
whether
it
it is
safe
there.
to use the pigtail probe?
Definitely, I'll
Because
send.
mostly,
So
as
if
you
you send me the
showed,
detail, I'll finish this
what
session and give
you
you a
told
call
was
after
this
1 hour.
calamari sign. It is
I mean,
basically
yeah,
that you
it's
are
a
able
calamari
to,
sign,
it
yeah.
is basically you are able to see the distal
definitely
part.
do.
But
Send me
generally,
details.
I am not able to see the distal part. So even if I put adrenaline, so generally what I do is that
Take the
from the
full-
other punctum, you
full-
either put in air or water and see the bubbling.
True.
But at times, say if it is delayed more than 48 hours, even that doesn't happen.
Right.
So using a pigtail, won't you damage the?
So because the pigtail is blunt,
Yeah.
and hopefully within that short period of time you don't have fibrosis at the common canalicular end, it usually doesn't cause a false passage. But if you try too forcefully, especially in delayed cases, then the tip of your pigtail probe can actually go through that fibrosis and create a false passage, which invariably will again close later on. So
Thank you.
Thank you very much.
Thank you.
Anshuman.
Yeah.
That was a wonderful presentation.
No, your mic is not on. Yeah.
Over to Kavita for her anterior segment trauma tips.
Thank you, Dr. Natarajan, for having me be part of your wonderful IC. So I'll be talking about how to manage anterior segment trauma. I think corneal trauma is essentially the second major cause of blindness. And it's very important to know how to manage this because it's affecting mostly younger individuals, probably kids when they're playing, or it's usually an occupational hazard, like, somebody is working. So not only does it cause obviously an emotional trauma because they at a young age they're undergoing this visual loss or potential visual loss, but also he's going to take that much time off from work. So the psychological and economic trauma, history taking is very important, especially if it's happening at work, that how it's happened, what was the object, what was the size of the object, because sometimes you may miss out a potential retained intraocular foreign body if it's like if he was using a hammer and chisel especially, and whether that like what force that when he's trying to chisel something, did something enter his eye, because then you have to look for a retained foreign body, or if it's just a small or like a large object which went and hit his eye, which is going to be more in terms of just a blunt trauma but or not in retained intraocular foreign body. And of course you have to see what he has been treated elsewhere, what medications, the antibiotic and the tetanus prophylaxis as needed. Visual acuity, pinhole, and the projection of light is very important, especially if you see something like this, make sure at least you're looking at the pupillary, like the consensual pupillary reaction, figure out what's going on. And this is important, like, you know, because if you see something like this, then make sure you're documenting all of this when you pay for taking up the patient for surgery. Also, Dr. Natarajan stresses a lot about taking a video consent, like consent and counseling, very, very important, because when a patient comes with this injury, next day he's going to expect 6x6 vision, and so you may need to make sure, and then he's going to say, oh, you did my surgery and I can't see. So he's never going to know, unless you counsel him and make it very, very clear that this, if you're not seeing, it is because of his injury, because of the impact of the injury. Because in the patient's mind, he's always going to associate the post-op result with your surgery and not with the injury. So you have to make clear that you de-associate the two things, the surgery and the injury, and put all the blame on the injury. So just save yourself and, you know, just no, that's joking, but make sure that you know, counsel the patient properly, and examine the patient on slit lamp, look at the extent and depth of the laceration, also look at the uveal tissue for viability, see if the lens is affected, vitreous. And sedal tears, sometimes you'll feel like, you know, it's a lamella, especially these so-called self-sealing tears, you know, where patients have been told that yes, you don't need surgery, and they come back with end-off to us, because the patient is not going to just go around without touching his eye. He's going to rub the eye, squeeze the eye, and that's going to open, even if it's opening, like, you know, temporarily. Look for the sedals test. If the sedals is positive, even if it's so-called self-sealing, please go ahead and suture. Karubi ma'am has talked about at length about this, so I'm going to skip this. Management of the corneal tear, if it is very small, like even sir was mentioning, are there any cases where you don't need to do anything? Yes, if it's very small, sedals is negative, very like less than 2 millimeters, you could use a glue, but I would avoid using a glue if it's in the visual axis, because that glue is going to cause a lot of haze, scarring and vascularization. But if it's a peripheral, small 2 millimeters, then you can use glue, and these patients do very well, okay, especially if it's a younger, like, you know, a child, or, you know, who's, you're worried that if it's, you know, like sutures, again, you have to go back and take out the sutures, because the glue is just going to fall off on its own. So like I said, you can use glues if it's smaller, peripheral. Now, when you're suturing a corneal tear, it is really not like just suturing any other part of the body, not like suturing the eyelid, unfortunately. I mean, I wish it was that simple. Here, what is happening, it's the first lens of your eye. It is the first refractive surface of the eye. So at one point, you want to get structural integrity, but at the second point, you want to like also maintain corneal asphericity, which is the cornea is steeper in the center and becomes flatter towards the periphery, because the minute you lose that, you're going to get heavy astigmatism. You may feel you've done a wonderful job, the child you've sutured him, he lands up with -9, -10 astigmatism. It's useless to that child. So make sure you're keeping all these principles in mind. Now, whenever there is a tear, there is an effect of the laceration on the cornea in terms of astigmatism and altering the topography. There's an effect because you're suturing the cornea, and of course normal wound healing. Now, what happens when there's a tear? Basically, it's flattening. If you see, the center is completely flattened out, and also if you suture, it's going to flatten in that periphery, but it's going to get steeper away from your suture. So how do you decide the length of the sutures? What you need to do is make sure that the sutures are completely placed in such a way that each suture, the zone of compression, is overlapping the other zone. So that length has to be long enough. Now here, if you see, and let's go to the next picture, you can see, like, if you're taking shorter sutures far away from each other, here there is no zone of, the zone of compression is not overlapping. So it's going to leak in that zone. So the thumb rule is that the length should be, it should be longer sutures. Now how should this, and how deep should they be? If it is, ideally it should be at 90% depth, and most of the times we are able to maintain this depth. And make sure that you're like holding the needle a little away from the tip, because if you go closer to the tip, you're going to go more superficial. So hold it away from the tip and pass the entire thing, and that's how you will do well. Now, entry and exit bite, it's a myth that if the tear is perpendicular, then your entry and exit will be the same distance from your surface where you're seeing. But if your tear is oblique, then if you try and make the entry and the exit point at the same area, then it's going to cause overriding. So be mindful of this also. This is how it will look at the end. You know, the entire arc should be at one, symmetrical. So what you should need to do is imagine a perpendicular line and pass your sutures. Now this is very poor suturing. This has been obviously seen by us, done elsewhere. Why I'm saying it's poor suturing? Because it's a lot of malapposition, and look at that exposed knots. That's a complete no-no. Please do not leave the knots like this. 10-0 sutures can easily be buried. This patient was very, very symptomatic, and we went ahead and did a resuturing for her. So now lineal tear, corneal tear. This is please remember this. If your your tear is through and through, the central sutures will be shorter and peripheral are going to be longer, and long and tight in the periphery and short in the center, because like I said, the sutures are going to cause flattening. So keep it shorter in the center. If you have angular tears, now if you see this tear, it is an angular tear, and the angle is actually here, it is away from the visual axis. So what I'm doing is I'm going right through the angle and passing through suture. But had that tip of that angle been in the visual axis, I would have done it and passed it through the other arms of that angle. Now, if you stellate something like this, these are the most difficult, it's very like, in fact, the OR staff also gets impatient because it's very difficult to close these sutures. Sometimes in the end, you may just have to put a little bit of tissue adhesive or put a BCL at the end. And this purse string suture has been described in literature for whoever wants to try. I think this also is a great technique. Now, another tip here is that if you see that there is iris in the wound, the tendency is to go through the corneal tear and keep pushing the iris in. That's the worst thing to do, because at that point the cornea is so friable, you're going to cause some corneal loss. So some tissue is just going to snip away. So what you should do is as simple as that. Just go in through the side port, inject viscoelastic. In 90% of the cases, the iris will just fall back and your life becomes so much more easier. So don't try and ever push the iris in through the corneal tear. That's a complete no-no. Now, what iris do we retain and what we don't? If it's prolapsed for more than 24 hours, ideally it should be cut. Sometimes you could retain, use your own judgment. This, of course, has to be retained. It looks healthy. Even if it's not a very fresh tear, you can retain. Something like this, no, a complete no. Something like this, of course, is a complete no. You're going to go ahead and excise all of this. So there's no two ways about that. Now, this is very interesting because it doesn't really look like a corneal tear, but this was a corneal tear. This patient came with this extensive tissue loss. Even on the right-hand side, it was very, very surprising that this is how the patient came. In fact, I was so shocked to see the injury was probably 15 days old, and the patient was in the village somewhere. So you have to go ahead and do some kind of a corneal transplant. Like I did a patch graft and I did a corneal transplant in the other patient. If there's vitreous incarceration, of course you have to do a vitrectomy. Sometimes you may have to take your help of the retina colleague because the extent is not seen. You have to keep suturing as much as possible. Now, what happens when there's a corneal trauma with cataract? Ideally, you're supposed to wait for 3 months, get all the sutures out, and then plan the cataract surgery. There are some cases where you will do a primary cataract surgery. If it's a child, in an adult, if the capsule is ruptured, logistical issues sometimes, like I'll show one case, or if you're combining a case. Now this, you can see the picture. This is how the patient came. Nice corneal tear, not very large, but the patient was a child and with a nice ruptured lens capsule. So we did sutured the tear and we also put in the lens at the same point. This is another patient of mine, the graft rupture, but because logistically she did not want to come back and she was from the village, we did both at the same time. We used the IOL measurements from the other eye. Just have a few more pictures here. You can see this is where I've done a primary tear suturing, then secondary, and this is where you're doing it sequentially. This case is again you're just simple. You're just aspirating the cataract, inserting the IOL, and the other case below is where you're doing a vitrectomy. I'm just showing the case below because the sutures are not out, but since the patient had a vitreous hemorrhage, patient came from elsewhere, we still had to go ahead with the surgery. And this is another case, traumatic cataract with mydriasis, where you can go ahead and do a 4th row pupilloplasty after addressing the primary cataract. So this is how the result is. So in conclusion, you suture maintaining the keratorefractive principles. Make sure you maintain corneal asphericity and decrease astigmatism to improve the outcomes. Thank you.
Thank you, Kavita. Just one question for you. If you have a cornea which is not faring too well after your traumatic cataract, after how many days you would do the keratoplasty? And yeah, that's the question.
So if you mean in terms of corneal edema or just the corneal
opacification.
So I think I would at least wait for, if it's a child, obviously, because you're worried about amblyopia, I would move faster, maybe 3 months. But if it's an adult, I soon see no harm in waiting for 6 months, giving that cornea time to revive, and then plan the keratoplasty, endothelial, or full thickness as needed.
And what about IOL, if you have to put it, if you've just done a plain simple cataract extraction at the first go, after how many days you would put in a IOL?
You mean if you've done a corneal tear in the first, if just done a lens aspiration?
Lens aspiration, corneal.
So again,
tear,
like that the case which I showed, in fact, it was a child, it was I think a 6 years old child. So we just used the IOL measurements of the other eye. I talked to the pediatric ophthalmologist, and we decided, because it was a peripheral tear, I didn't think it will cause so much of an effect on the biometry. So we put in a primary IOL, but had it been an adult where you're just, the capsule is ruptured, I would have sutured the corneal tear and maybe done it like at around, ideally they say at 3 months. But I know in practical situations, sometimes I would say it's best to wait for at least 4 to 6 weeks.
Thank you so much,
Thank you,
Kavita.
Thank
That was a very nice talk.
Thank you,
Inviting Professor Natarajan to come and speak on traumatic endophthalmitis to us.
Thank you, sir. Thank you. Thank you, Kerubi. And I think I have the luxury of having Dr. Kavita Rao and Dr. Akshay with me, so I don't have to plan all this, but fortunately, we are a 24/7 ophthalmic trauma center and we manage as a team. So ocular trauma is a true emergency, and I think one of the 5 emergencies which call, and traumatic endophthalmitis is the double whammy emergency. And I thank Aishwarya Iyer who's going to speak next to me, who put the program together. So the introduction is that post-traumatic infections of endophthalmitis occurs in 2 to 7% of all penetrating intraocular injuries, 7 to 31% of injuries with retained intraocular foreign body, and perforating injuries that occur in a rural setting result in a 30% incidence of endophthalmitis compared with 11% in a non-rural setting. Endophthalmitis complementing penetrating ocular injury generally has a worse visual prognosis than does post-surgical endophthalmitis. So the open globe injury, which already we have seen this. So actually, maybe it's a long, I don't know how much, we can't fast forward this. So anyway, this shows the types of injury, and I'm skipping this video because it's a long video. So you have seen these are the signs of endophthalmitis following an injury like eyelid edema, chemosis, purulent exudate from the site of injury, corneal edema, hypopyon, severe antechamber reaction, vitreous exudate, retinal periphlebitis, and pain out of proportion to the injury, decreased visual acuity, photophobia, tearing, pain with eye movement. And we have this international globe and adnexal trauma epidemiology study called iGates, which is, you can see this as a study book created by Dr. Rupesh Agrawal. And we want a strategic management for endophthalmitis, emergency removal of the foreign body, complete microbial culture and sensitivity, administer antibiotics, intravitreal, subconjunctival, topical, and possibly intravenous, contrary to the post-surgical endophthalmitis, and definitely plan a pars plana vitrectomy. And I think this is a true emergency. So here, you have a patient with a traumatic endophthalmitis with corneal abscess, stone injury. Again, thanks to Dr. Kavita Rao, who always comes to rescue. We plan to use the temporary keratoprosthesis. We have the ACART, and there are many available now. And we use the temporary keratoprosthesis replaced by a donor corneal graft tissue at the end of the procedure. So this is a vitrectomy with the temporary keratoprosthesis. And here the video, we have the application of the temporary keratoprosthesis. There's a flaring gas ring in place, and then you can see the corneal. In this case, you can see the cornea is infiltrated because the patient came quite late. There's like a thick phlegm removing using the regular anti-segment forceps, and then now this is Dr. Kavita Rao placing the temporary keratoprosthesis. You can see the corneal necrosis even in this rim, and she was saying, is it worth doing? But I said we should not give up, and I know you may think it's wasting a tissue, but no, you're saving an eye. First you're saving the eyeball, and then hopefully vision. This patient, you will see, it looks so bad, but to our surprise, you will see because of the patient in coming late had a corneal problem, but there was PVD, and the exudates was thick but took time. And here you, this is a quite a old video with a 20 gauge infusion line. And Swelleringer ring is in open eye, the open sky is important to prevent expulsive hemorrhage. You can see now the view is fantastic because the temporary character process has an excellent view, and you can use the wide angle observation system, whatever you have, preferably a non-contact, and you can see the thick, you can see the infusion line in position, and you can see the vitreous exudates are being cleared, and you can see now the optic disc in the without the cornea there, and Dr. Kavitara doing the cataplasty and making sure that eye looks all right. So this is an eye we planned temporary cataplasty with vitrectomy. There's a patient with a trauma, 20 days old history, and you can see the eye with a totally necrotic cornea with a corneal suture. And this again, we have to create awareness to the rural India for sending the patient early, and they are usually worried because the patients are very violent. And so we saw this eye, we couldn't do a temporary cataplasty. We did an open sky vitrectomy. I don't know what I'm removing. We have a senior anesthetist, Dr. Sharma, who's asking, are you doing a micro evisceration? I don't know, whatever it is. The idea was to save the eye because a young person, and to save the only thing is if the patient goes from endophthalmitis to panophthalmitis, you will be able to abandon and do an evisceration, because panophthalmitis, there's a risk for death also. So here you cleared all the exudates, you saw the iris being cleared, and this wound reconstruction was done, and then Dr. Kavita takes over and does the corneal suturing and intravitreal antibiotic given at the conclusion. The patient had about counting finger close to face, but this cornea usually is many times unplanned, because then we use a preserved cornea. And many times, if the visual potential is there, and if the cornea becomes, I think probably a repeat cataplasty has to be done as an optical. So this is again an eye with I use a AC maintainer, learned from Dr. Cesare, late Dr. Cesare Forlini, who uses a lot. And this is a diffuse endophthalmitis post-trauma with where intravitreal candidate was given, but now you can see I'm using AC maintainer as intraocular infusion, and then proceed with clear. And now I'm doing 2-port vitrectomy, and you can see the vitreous exudates in the posterior cavity, and there was no PVD, so you have to be extremely careful, because exudates will produce toxins, and toxins can produce necrosis of retina and thereby rhegmatogenous retinal detachment. So there are some eyes we inject silicone oil at conclusion, but for that you have to remove as much as possible of the infective material. That means you have to do a aggressive vitreoretinal surgery. So this is the first post-op day, no hypertony, no leak. You can see the cornea clear, the intraocular view is also good. And then 6 weeks later, the patient had 6/18 vision. You can see the eye is quiet and the fundus is seen very well. And this is the 4th case with the firework ocular trauma. That's why glad there is some thing we have done advocacy by Dr. Grover, Dr. Lalit Verma of AOS and OTSI, and iGates, Dr. Rupesh went, and we are hope that my thing is we should ban cracker bursting by the children. This is a 6-year-old male with a left eye ocular trauma with firework on 24th October in 2017, present with a corneal tear with exudates in anterior and posterior segment in the B scan. This is the preoperative B scan, and this is the patient. We again anterior segment approach. We can see the exudative material on the surface of the iris. We clear it, and there was a continuous oozing happening, so the view was not clear. So I changed from infusion to air to stabilize the bleeding, and then now we can see after clearing the anterior segment, clearing the posterior segment. So the necrotic tissues are there. Particularly, you have to be careful going closer work to the retina. So have suction less, high cutting rate to avoid retinal complications. So the patient should know, as Dr. Kavita said, we take a video consent, and then we proceed with the vitreoretinal surgery, and we have saved many eyes, maybe not vision, but the patient is happy that you are not removed the eye, because this is what I recommend. However bad the injury is, even if it's no PL, and if there's no panophthalmitis, I think you are justified in doing surgery. and we should do the best to recover anatomically and functionally. So unless we do the anatomical recovery first, then only we can get the functional improvement. So at conclusion, you can see the post-operative B scan where most of the things are cleared. So I think never give up. And to conclude, numerous prognostic factors may affect the visual outcome in case of post-traumatic endophthalmitis, including severity of initial trauma, time interval between trauma and treatment, and virulence of the infecting organism. That's why we have to make sure that I remember another patient from Jaipur. I think we're doing intravitreal antifungal injection for almost myself and I think it was Dr. Chinmay at that time, alternatively giving injection to make the eye quiet. Finally, the eye became thysical. We refer to action eye. But the question is, we prepare the patient. I know it's a long treatment, but you can imagine if in your own family somebody has, and if you save the eye, they are grateful to you in spite of the person did not get a vision back. But the idea, they know that you have done the best, tried several times to get vision. I think most of my trauma patients may not get any useful vision, but I don't know why they call me God, but I'm not God. And thank Dr. Jaydeep, Dr. Kavita here, Dr. Akshay, Aishwarya, Afroz, and Samir who has done. Thank you very much.
Thank you, Dr. Natarajan.
Mike is not ready.
I have one question for you.
Yes.
If you are doing a eye which has got bad cornea and you put a TKP, and suppose you don't have a donor graft, what do you do?
Now we have a preserved cornea we can get, correct, Kavita? Somehow we can use the preserved cornea.
So preserved cornea, you'll get it from the eye bank. Okay. And they always have a supply of it, or sometimes they don't have that also? A cover. Yeah. Right. And in cases of bleb endophthalmitis, if there's a trauma to the bleb, and you go ahead and remove all the exudative material, and at the end of it, you reconstruct the bleb by probably putting a flap from behind across the bleb site. And if you have a persistent hypotony, what would you do
Post surgery.
post surgery?
I think then you may have to do a surgery, refer to a glaucoma surgeon for removing the bleb and do a valve.
But it's a hypotony.
No, I know. What I'm saying, the hypotony is because maybe the trabecular meshwork is draining a lot through the bleb. So you can probably destroy the bleb and use them, or you remove the bleb and do good suturing and leave it and see what happens.
The case is on sympathetic ophthalmitis.
Next session
It's
is
a very
like
rare
trauma.
complication of ocular trauma. So I'm just, I've had the fortune to have two cases
foreign
come to me. I'm just going to talk about those.
Earlier when he was opening site.
Just a small overview. So it's a bilateral diffuse granulomatous uveitis. That's the definition. And it occurs to the good eye after a trauma or an intraocular surgery to the fellow eye. So the pathology, just a little bit, it's a type of autosensitization of ocular tissue following a perforating injury to one eye. So it's an immune response, basically. Okay. So the eye that is injured is the exciting eye, and the contralateral eye is called the sympathizing eye. So let's see the first case. There's this 32-year-old male. He was a gardener by profession, lower socioeconomic status, and he presented with a painful red eye, and he had photophobia, watering, blurring of vision, the typical. So his past history, he had a penetrating injury to the left eye with a thorn like 6 months ago. No other systemic illness. So obviously when you know that you've had a trauma to one eye and the other eye is presenting like this, all red flags are going to go up. But that really doesn't mean that you have to ignore all other causes. You do have to work up this case like a normal uveitis case as well. So this is a clinical picture that we got. So the right eye BCVA was just hand movements and PR accurate. IUP was 38, and the anterior segment, you can see the pictures. I'll show you clearer pictures in the next slide. There were these mutton fat KPs, there was flare, pupil was fixed and dilated, there were multiple posterior synechiae, and the retina showed a lot of vitreous cells in the vitreous, optic disc edema, and there were focal serous retinal detachments. Had there not been a trauma in the other eye, looking at this, what would have been your obvious conclusion? What would your brain have gone to? Any suggestions? What would you think? Anything? Yeah, like, so granulomatous uveitis, unilateral, and if there was no trauma and the retina is also showing these focal, serous detachments, you would be like, maybe it's VKH, right? So your brain would go towards VKH, which is, yeah, the most obvious DD for this. But the other eye looks like this, as you can see in the other picture. So now further red flags are going to start going up. So you can see the KPs, those mutton fat, typical bad KPs. And so we did a workup. See, just because there was a trauma doesn't mean you ignore it and be like automatically jump to conclusions, right? So we did the workup, we did all the blood investigation, CBC, CRP, ESR, the usual battery, VDRL, including serology, everything was normal. B scan was done. This is what we saw on B scan, okay? And we did an OCT macula also showing a serous detachment. So now we are thinking further. We did an FFA as well. Unfortunately, we don't have the images because our machine broke down. But the FFA had this very typical early phase, early phase, there were these leaks, pinpoint leaks initially, which then gradually expanded. And in the late phase, there was staining. So we made a clinical diagnosis of sympathetic ophthalmitis after ruling out all other possibilities. We cannot go to that diagnosis without ruling anything else out. Let's go to a second case. 50-year-old male, a plumber, presented with left eye, painless red eye, photophobia, watering, gradual progressive blurring of vision since 10 days. And he had a trauma to the right eye with a stone 5 months back. It was treated as a perforated corneal ulcer, no other systemic illnesses. So you can see the right eye, PLPR inaccurate, bad looking eye, and the left eye was looking like this, ciliary congestion, KP cells, typical again uveitic picture. However, in this case, we did see something else which was a little more interesting in the retina, something very textbook called Dalen-Fuchs nodules. Dalen-Fuchs nodules are these subretinal deposits, and they are not, you can't say they are pathognomonic, but they will lead you towards sympathetic ophthalmitis in the absence of anything else. You can be a little more confident with your diagnosis when you see something like this, and they light up beautifully on FFA as well. So yeah, FFA showed multiple diffuse punctate hyperfluorescent spots at the level of the RP in the early phase, which persisted with increase in hyperfluorescence in later phases. There was pooling of dye infrotemporally, which told me it's one exudative RD. The B scan showed a choroidal thickening with an exudative RD infrotemporally, and again, after ruling out everything else with a thorough blood work, we made sure nothing else is there systemically, and we made the diagnosis of sympathetic ophthalmia. In both cases, we started the patient on steroids sufficiently early, sufficiently high dose. So we gave 80 mg per kg and gradual tapering, and the patient gradually made a wonderful recovery. He came back to 6.6 from 6.36. So sympathetic ophthalmitis is nothing to be scared of. You don't see the case and be like, oh my God, this is hopeless. We can't do that. It is salvageable. We can bring the patients completely back. So yeah, just a little overview. So about in 1000 AD, one guy called Hippocrates, he said that in the right eye, which when diseased often gives suffering to the left. This was a vague description of what sympathetic ophthalmia was thought to be about. So in this, both eyes are affected. And now, is prevention better than cure? This is the most controversial question when it comes to sympathetic ophthalmitis. Should I enucleate? Should I not? But now we don't do that anymore because we are having much better forms of managing ocular trauma. Quick and careful surgical care of the wound, early proper closure of all penetrating wounds can prevent. Now the incidence in 2011, the incidence of sympathetic ophthalmitis in case of trauma was 0.9. Today it's only 0.2. So that shows a long way that we have come, in preventing this devastating complication of ocular trauma. So yeah. In eyes where no vision gain is possible, enucleation within 2 weeks after the injury can prevent SO, and delayed enucleation more than 2 weeks is not preventive. It's not going to help. You would have unnecessarily enucleated a patient. Yeah, corticosteroids. Use of steroids following the trauma before the development of sympathetic ophthalmia has seen to be of no use. So, unnecessarily pumping the patient full of steroids is also useless. Steroids are the mainstay after SO has set in, and anti inflammatory action of the steroids is used to suppress the inflammation completely as soon as possible. Loading dose of IV steroids with tapering orally or high dose of oral, depending on the situation as you see fit. And subtenons, depot steroids may be added for posterior uveitis, and topical steroids as a marker for marked anterior uveitis. In addition, of course, mydriatic cycloplegics can be used. So now option 2, in patients where you cannot give steroids, you can try immunosuppressive agents like azathioprine, methotrexate, chlorambucil or cyclosporine. Definitely a full systemic workup has to be done before you start the patient on these things. It would be preferable to work in conjunction with a rheumatologist or an immunologist, somebody who can guide you on the dosages if we are not sure. Sympathetic ophthalmia is a serious vision threatening disease, but with modern therapy, there is plenty of hope for patients diagnosed with this. Even the exciting eye can have reasonable visual outcome with prompt and aggressive treatment. So, right now, in this day and age, sympathetic ophthalmia is not devastating, all is not lost. And I think with careful monitoring, we can bring the patients back to 6/6 like we did. Thank you.
Thank you, Aishwarya. What is the first sign of sympathetic ophthalmia? First sign? No. No. Homework. Huh? Even Parsons. Both. Anyway, homework for you. One important thing I want to tell is I think we should remove the thinking of enucleation at all, because I am talking all the time vitrectomy for no PLI and no primary enucleation, no primary evisceration. No, primary.
Not happy with that.
No, falling. I told you, I appreciate it when
hope is
I
lost,
produce
we will-
thesis bulbi, then refer to you.
Yeah,
So then
only
the patient is
once-
ready
once
for
there's no hope.
our. Yeah, no, family, when a child is injured, entire family is devastated. So the earliest sign is important to pick up. So for the sake of audience, the Parsons writes is the patient, I remember a 16-year-old following 4 vitreoretinal surgeries in Hinduja had a reading vision problem. The first thing will be the accommodation spasm. So that's the first sign. People miss it. You start aggressive treatment, and that's how they have now recoined, Dr. Narsingh Rao and JB, is a bilateral uveitis, the sympathetic ophthalmia. That's why they have removed the word ophthalmitis to sympathetic ophthalmia. So I think you have to pick up early and treat. And then second is no enucleation, and important while doing wound repair, particularly posterior to the cord, like even the scleral tear, you make sure that no uveal tissue is in the tissue. So wash well, and probably you can use viscoelastic to push the material if it is a fresh wound.
Minimal handling of uveal tissue as possible.
Yeah, that's right.
Also, you have to see that you reach the farthest end of the scleral tear. Yeah, I mean, you suture this, otherwise you'll land up with chronic hypertonia or whatever. I wanted to ask you, what about the use of Ozurdex in a case of sympathetic ophthalmia, in case a patient is a diabetic?
It takes way too long to act. I mean, by the time we can get any response from Ozurdex, I think patient would have oral steroids and
Oral
IV
steroids, then in that case, if you want a faster this, would you consider methylprednisolone?
Yes, absolutely. If it's a very fulminant kind of anterior uveitis, we generally start off with
1
3
gram
days of IVMP
for 3 days.
and then go into the oral steroids. That will be
Okay.
the fastest.
But if a patient is an uncontrolled diabetic, then also you would think in terms of this?
Because it's like a pros versus cons situation.
No,
But
with the diabetologist.
Yeah, we collaborate with an endocrinologist and ask
Okay.
him to up the insulin or give an infusion of insulin while this is going on.
Okay, fine. Thank you.
Thank you,
Any
Aisha. Can
other
I have the
questions from
speakers and
audience?
Dr. Naresh? We can have a photograph. Dr. Ayantika, you can take the photo and
Anyone
send to us.
has any questions
And we
for
have,
Aishwarya?
I'm happy, we
Yeah,
have Dr.
please.
Santosh Mahapatra.
She
Yes,
has a
madam.
question.
Yes. No, so in under systemic monitoring, if you're giving IV steroids, better to get the patient admitted, give IV methylpred, first 3 days loading dose, and then go on to an oral tapering. If the uveitis is not so fulminant, you can start off straight away with oral steroids itself, along with a pantoprazole and a calcium supplement And if the patient is a diabetic, consult an endocrinologist to monitor the sugars.
And also anti-mitotic drugs will help if you pick up the uveitis early, start steroid, then supplement with the anti-mitotic drugs
Methotrexate would be the best bet.
so that you can. So we have a
Intensive course.
next instruction course is also on trauma. Dr. Santosh, we'll have a group photo and then you can take over. So can you have the speakers and Dr. Naresh? Santosh, I'm from morning 9, I'm here. Can I give my talk and go and have lunch? And then I have one more session. Or no, you want to? No, first talk I'm saying. Can you come and take? No, you go here, sir. Come here. How are you, Naresh? I'm fine. How are you? Wonderful.